Welcome to the Pardee Center. My name is Adil Najam. I am the director of the Frederick Pardee Center for the Study of the Longer Range Future. We are delighted to host this event, to host all of you here, and host it jointly with the School of Public Health and the Global Health Initiative within the School of Public Health. So we welcome all again. We tried very hard. We worked with the Met Office to make the weather as compatible to South Asia and India as we could. Okay, I will speak louder. Thank you. That is actually a good caution to all the speakers to speak a little louder. We are actually very delighted to have a large audience in the summer. In the summer, usually universities sort of empty out. But it's good to see a good crowd here, and we have a very interesting discussion. I won't go into the details of the panel today. Jerry Kirsch will do that in a minute, but I did want to welcome you to the Pardee Center. The center, as the name implies, is about the study of the longer range future. That does not mean that we are in the business of predicting what the future is, but we are in the business of trying to anticipate, to project, to prepare for the futures that we desire, to think about trends and things that are going on in the world right now, and to think about how those can be aligned to trajectories that will lead us to a better future. And of course, health and public health is a central component in that, which is why a lot of our work does in fact tend to lean on issues related to health and development. So with that, and welcoming you again, I'll hand off to Jerry Kirsch, who's going to be moderating this very exciting panel, and he will tell you more about the panel and the participants. Jerry.
Thank you, Adil. The connection between the Pardee Center and its interests and the medical campus and all of the schools on the medical campus, the medical school, the dental school, School of Public Health, have really come together over the issues of the future and development and our mutual interest in the developing world. This is one of a series of meetings that we've had. The last time I was here sitting up front, Adil was moderating and I was on the panel, so now I've turned the tables on him and I can try to control him as he tried to control me. The rationale for this conference is very opportunistic, and we're taking advantage of the presence on campus of, first, a group of people from India who are the new faculty for new efforts in training a public health workforce in India. A huge investment of time and effort and resources, and potentially hugely transforming, as health is one of the driving forces of development. And India has big problems and big opportunities, a growing economy, and lots of smart people. So there's a real challenge to make the most of this opportunity. And we are hosting a group of people who will be the faculty in these new schools of public health for a program that we've jointly established with these two new public health efforts in India, the Public Health Foundation of India and the Indian Council of Medical Research. And I'll introduce our principals from those efforts in India in just a moment. The group is involved in a course which is a first time for us, and certainly a first time for them, which is oriented towards teaching how to teach. And most of us have had lots of experience being students, and then if you are in an academic setting, you kind of learn to teach on the job. You probably make mistakes that you don't need to. And we thought that there were tools and concepts that would be valuable as this effort goes forward, and where all would learn. So we have a group from both the Public Health Foundation and from the Indian Council of Medical Research. This is week 3 of an intensive program, and they've been working very hard and thinking about the issues of health development, public health, the role of public health practitioners, and how you train a workforce in a country of over 1 billion people. It's a bit mind-boggling to think about that. We're also graced at the moment with two principals in these two new efforts. Professor Srinath Reddy, right here, and you can loosen your tie if you'd like to, is a renowned cardiologist, was the head of cardiovascular disease at one of the premier schools, medical schools in India, the All India Institute of Medical Sciences in Delhi, is a physician who has, because of his interest in cardiovascular disease epidemiology, become a public health person. He's dealing with population level issues and has been a leading force and now the first president of this new effort in India, Public Health Foundation, which intends to create a set of new schools teaching public health in a new manner for India and its future. So we're really delighted to have Dr. Reddy here with us. On my immediate left is Professor V.I. Mathan, who I've actually known for some 20, 25 years, and we have been research collaborators in the past. Dr. Mathan was the head of the Christian Medical College in Vellore in South India, another one of the premier medical schools in the country. He's a gastroenterologist. As I mentioned, he became the head of the institution, and then spent a few years at the International Center for Diarrheal Disease Research in Bangladesh, returned to India in Chennai, and has been the Indian Council of Medical Research Distinguished Professor of Epidemiology, sitting at the National Institute of Epidemiology in Chennai. And it's that institute, one of the multiple institutes of the Indian Council of Medical Research, that's building another set of new schools of public health. And I won't say what their future vision is, because that's what they're here to talk about. So there are these two efforts to build new schools of public health to address the health-related development issues that India faces today, and more importantly, as India develops, what will it face tomorrow, and tomorrow in the sense of that longer-range future that Adil just mentioned. We have two discussants to respond to some of the points that our two distinguished guests make. Deborah Main is a professor in the School of Public Health. She has a long and distinguished career. She's been most interested in maternal and child health, has led major worldwide efforts to identify issues that are solvable in improving maternal health and survival. It's true all over the world, and even in the United States, that a household without the woman doesn't really work. So women's survival and health is extremely important all across the board. And she's had lots of connections and work in India, and we asked her to reflect on the comments of Drs. Reddy and Mathan. And then Adil Najam has his own perspective. He is from the subcontinent. He has his perspective. He is one of the most educated people I know. He keeps going back to school to collect another degree in another field, but they're all related. But the two that I think are most relevant are his work as an environmentalist and working with the UN on some of the climate control issues, as well as his position in international relations. And those two connections, connecting with our interests in health, just form a wonderful nexus of relationship. And so we've asked Adil to comment at the end. But then the purpose of this is to throw the discussion open, because the vision of the future really should belong to the younger people who are going to be the leaders tomorrow and the day after. So we'd like to have a dialogue. We don't want to be talking at you. We've asked initial comments to be brief, and then we want to throw it open for as vigorous a conversation as we can have. So that's the plan for today. And who would like to go? You're pointing at Reddy, and Reddy's pointing at you. So I'll pick you.
No problem.
And I think this is for recording
This is for
purposes,
record.
not for the audience, right? Yeah.
Thank you. Can you hear me at the back? Jerry, as always, it's wonderful to be back here in Boston and very stimulating to interact with you and the others in the course. I've been warned strictly by Jerry that I have 10 minutes, and he will be a very strict timekeeper. And actually, prediction of the future can last for many hours or should last only a few minutes. Because in any case, you are talking about something which you don't know, and you hope it will turn out the way you think it is. It's important to keep India in mind when you think of the future of public health in India. It's a population of about 10.7 billion, give or take a few million, of whom about 30% are what we call the affluent population. About 4% are as affluent or more affluent than the people in the United States, because if you look at the last Forbes list of the world's richest people, I think in the top 10 there were 4 from India. But if you look at the other 750 million people, they are virtually living below the poverty line. And when you talk of the public health, they are the ones you need to concentrate on. Now, India, at least certain people in India, pride themselves on being the mecca of medical tourism. If you want a quick and cheap knee replacement or a quick and cheap coronary bypass compared to what you would spend in this country, catch the next flight. There are package tours available which gives you the surgery plus a 2-week holiday in a seaside resort and come back at about a quarter of the price of what it would cost you in this country. But as an Indian and as a health professional for the last 55 years, I am ashamed of my profession in India because we have failed to offer the fundamentals of healthcare and health to the 750 million people. The government subsidizes these so-called health exporters because export is always subsidized, and that money is going to fatten their coffers. That's the situation today. Now, when we look at public health, and I had a very interesting discussion with the Dean this morning, the situation in India is totally different. There is no public health cadre as such, which is trained to be public health professionals only as you have in this country. There are medically qualified people who have got a postgraduate qualification in what we call public health, which some people call preventive and social medicine, others call hygiene. But they are primarily in academic medical schools teaching undergraduates public health, and they have no relationship to the practice of public health in most medical schools. If you look at state governments which are responsible for the health of each state, I think of our 34 states, about 9 have dedicated public health staff. And they are all medically qualified, and they have opted for public health for lack of a job in the curative healthcare system. Are they trained? The answer by and large is, other than what they have learned during their work, there has really been no training of them. So given the situation, what is the future of public health in India? The 2 initiatives which Jerry talked about, the Public Health Foundation of India and the Indian Council of Medical Research Initiative, have got slightly different foresight. The PHFI, about which Srinath will be telling you more, will be training, we hope, a very large public health cadre. The ICMR initiative is going to take medical professionals who are in the government health system and who are designated as public health people through a 2-year course to train them in the practice of public health out there. And it's our hope that in about 10 years' time, we would have trained enough such people to have one public health practitioner for every district in the country. And these will be people who already are supposed to have that responsibility but who have no training, who primarily keep statistics based on very poor data collection, who have no understanding of data collection or data analysis. They will be brought in, trained, and sent back to do a better job. Now, along with the Centers for Disease Control in Atlanta, for the last 7 years, the ICMR has been offering a Master's in Applied Epidemiology course, which is a much short off-campus course for training public health professionals who are in the government service. And it's our success in that training that made us decide that we need to go into a more formal MPH training. So far, we have sent 56 students back to the state governments, and their contributions to the state's health system has been so valuable that they have all been promoted up of the district and brought into the central secretariat so that the administrators of health can have access to reasonable data and reasonable data analysis. Not be where they are, but I guess the effect of that is that the governments want us to train more and more people. So this Masters in Applied Epidemiology course will continue. In parallel with that, we are starting the MPH, which is a full-time, in-service 2-year program. The first year, which is mainly learning all the theory plus practical experience in the National Institute of Epidemiology. The second year, they will go to what we call the partners in our venture, which are 31 national institutes run by the Indian Council of Medical Research, plus about 8 or 10 medical schools, to get further training in areas where they want to specialize and also do a field project so that they will be experienced. I think the Public Health Foundation of India initiative and ours are complementary and parallel. Ours is aimed primarily at training existing people who are designated public health workers and sending them back to do their jobs better. Whereas they will be training ultimately a very large number of fresh entrants to the field of public health. By virtue of the fact that those in the government service are medical, our intake is 100% medically qualified. They have a more liberal admission policy. But I think these two programs are complementary because the effects of the people we train and send back, should be felt in the shorter period because they are already in the system, whereas theirs will take slightly medium term as the numbers build up. Our first MPH course is starting on the 1st of July. Once the faculty who are here come back and recover from their jet lag. They are coming back this Saturday, so I think 1st of July is about right for making them start on their work. This year we have taken 25 students. All our students are sponsored by the government. They are paid their full salary and their seniority and all benefits are kept by the government so that there's an incentive for them to come and get a degree. Our Masters of Applied Epidemiology course also for this year has taken in 25 students. So we'll be training 100 by the beginning of, in 4 years' time. By 2012. I was born closer to 1912, Devi. by 2012-2013, our annual intake should be 100. And we hope that this will make a significant change in the short term in the practice of public health in India. What do we hope is the ultimate outcome of this?
So 1 minute.
1 minute. That's my concluding part. What do we hope is the ultimate outcome of this? Better information to the decision makers, because the people out there at the district level who collect the information are qualified and competent to collect it, analyze it, and send it in. Better control of epidemic outbreaks, which we have already seen by our MAE scholars. Better immunization, because that's the function of the public health service and the state governments. And better mother and child health, as well as nutrition. It may be utopian to think that this will begin to happen in 5 years' time, but I think our initiatives has already given rise to a beginning in the 3 states from which about 10 people have been trained already by us as masters of applied epidemiology. And that gives us great hope for the future. Thank you, Jerry.
Thank you. Srinath.
Thank you. It's a privilege to be here in Boston. May I just preface my...
Are you able to hear in the back?
No? Okay, louder? Okay,
the
fine.
microphone's only for recording purposes.
Okay,
so
fine.
you really
I'll
need
speak
to
up
do it.
louder then. I said thank you very much for this opportunity to come and interact with this group in Boston. I will only like to preface my statement by saying that when I left Delhi, it was cooler there than when I arrived in Boston here today. So you're preparing us for India was not exactly on the dot. Well, I will utilize this opportunity to firstly place the Indian health scenario in context, against which backdrop I'll explain the emergence and the mandate of the Public Health Foundation briefly. Given the time that's allotted, I'll take more questions on the Public Health Foundation in the question and answer session. But I'll interpret the topic that Jerry has given us on the future of public health, not merely in the Indian context, but on the overall global context. And then I will try and explain why some of our training programs are going to be fairly substantially influenced by the expanding understanding of public health, both in its mission as well as its content. Firstly, as far as India is concerned, we are in a very unique historical situation. We have a very young population. About 53% of our population is under 25. We have not only the opportunity of seeing these people contribute to India's workforce, but to the global workforce, as over the next 20 to 30 years, the largest expansion of India's population is going to be in the 15 to 59 year segment. And this demographic window of opportunity provides a great opportunity for accelerated economic development. But such development will not occur if there are inadequate investments in education and health to appropriately protect, promote, and harness these human resources. But of course, one has to look not merely at the utilitarian point of view of what the human capital might produce, but also look at public health as a human rights issue, looking at the whole issue of those who are not protected by access to adequate and affordable health care, as Professor Martin has said. And in this context, India's rapid transformation and transition poses multiple challenges. We do have an unfinished agenda of infectious and nutritional deficiency disorders. Our infant mortality rate is still about 58. Our maternal mortality rate is about 300 plus still. We have world's third largest, we have 1/3 of the world's TB patients in India, and I can rattle off statistics on HIV and malaria and so on. At the same time, we have cardiovascular diseases, diabetes, cancers, mental illnesses, injuries, all the post-transitional health agenda rapidly emerging or even established in urban areas. So given this multitude of public health challenges, we do require a comprehensive public health response, which so far has been lacking. both in terms of adequate expertise as well as resourcing in terms of financial support. Recognizing both the need and the opportunity, the Public Health Foundation of India has emerged to establish several institutes of public health across the country, where physicians as well as non-physicians would be trained in public health in a 2-year master's program, 1-year diploma program, the PhD programs, but also several short and medium-term training programs to address the needs of existing public health functionaries, as well as of academic researchers and others who may want short-term courses to build up their skills in specific areas. But what kind of courses do we want to run, and what is our understanding of public health? When we are talking of public health, the traditional understanding of public health as something as identifying and influencing the determinants of health at the population level to impact upon individuals remains quite intact. But the determinants of health themselves are now being increasingly identified to be far more diverse than before. Apart from the interaction of beliefs, behaviors, and biology at the individual level, we have perceptions, priorities, and pathways operating at the family and the community level. And at the national and the global level, we have the stage and speed of development, the distributional issues of equity measured in whichever dimension, whether it is gender, income, occupation, social status, and of course the whole area of the demand and supply of trade. All of these are influencing health, and these upstream determinants are becoming more and more important in a rapidly globalizing world. So when we are really talking about the role of public health in India, we are really talking about both influencing upstream policy as well as downstream delivery. And for this, ultimately, the two key concepts that we need to emphasize are interdisciplinarity as well as health systems connectivity. In the Indian context, these become very critical. Interdisciplinarity to understand the broader dimensions of health, but at the same time, health systems connectivity to ensure that there is adequate delivery. And the word health system and health services are becoming increasingly important in the international fora. There have been several meetings recently and several expert reports. There is going to be an interministerial health on health systems research in Mali next year, Mali in November this year, as a follow-up of a previous meeting in Mexico a few years ago, essentially addressing the whole area of health systems and capacity building and research in health systems. Health system, of course, goes beyond healthcare. It certainly encompasses the broader dimension of public health. But it also encompasses other sectors which are outside of the traditional health sector, but policies and programs in which there are activities going on which will have a profound impact on health, whether it's agriculture, whether it's urban development, whether it's water resources, whether it's education, environment. All of these impact profoundly on health. And the inability previously to engage with policies in these proactively and to provide a corrective response rather than a mere coping response has been one of the infirmities of public health. At the same time, at the downstream delivery end, public health has not adequately engaged with actual health system strengthening, with training of health workforce, in mobilizing the multiple stakeholders at the ground level, and making a robust health system easily accessible to a large number of people. And in India, as we are now developing National Rural Health Mission and the National Urban Health Mission, this kind of interconnectivity as well as multi-stakeholder participation becomes extraordinarily important. And the role of public health is to engage and energize each of these stakeholders and ultimately bring them together. But again, we are talking therefore of economics, we are talking of equity, we are talking of rights, we are talking of engaging the market. In many of the sectors, market forces are now ultimately dominant, and it's taken as a sort of axiom that the market is going to be an autonomous player. But the market influences public health substantially and cannot remain insensitive to the needs of public health. Therefore, public health has to now mold the market through a variety of ways and ultimately ensure that the market imperative and the moral imperative of public health find a convergence point very quickly. And we are beginning to learn this lesson to our great cost when we look at not only the whole food crisis that is emerging all over the world, the whole issue of global warming, or even the issue of zoonotic infections, which are not mere accidental. It's not accidental that most of the infections that have emerged in recent years, the new infections, are zoonotic. We only think of a technological response in terms of vaccines and drugs, without recognizing that huge areas of deforestation release hitherto contained vectors into the human habitat, that livestock cultivation on a commercial scale provides a captive veterinary population where this can spread in close contact with the human population. So without recognizing these multiple determinants, if we only use public health and health care as mopping brigade of policies gone wrong in other sectors, we will continue to play that very marginal role. Therefore, recognizing our broader mandate at the global level and at the national level, we have to build a new cadre of public health professionals who recognize this. And this is not entirely a new concept. Back in the 19th century, Rudolf Virchow, basically when he went to investigate the epidemic of typhus in Upper Silesia, came back not with a bacteriological or a germ diagnosis, but came back with a damning social indictment of the poverty and hygienic issues related to that community, asked for greater democracy, reduced taxes, and greater freedom. Now, from the loosely defined miasma of the 19th century, now when we come to the whole issue of environmental health and global climate change, again, we are looking at things from a societal perspective, but through a sharper lens. So in a case, in between, we lost our track a bit when our greater ability to look at the laboratory capacity and then look at the germ theory and then look at molecules and look at genetics, all of this sort of made us very focused on the individual. Now we are again beginning to get the social dimension. So public health research must now cover a spectrum from molecules to markets. And the arena of advocacy and action must move from risk factors to human rights. And that is the broad canvas that I envisage. And I believe whether it is at the level of a small village in India or at the global policy-making fora when we are discussing the governance of global health, this broader vision of public health must dominate in our thinking and our action. Therefore, I believe it's back to the future. We started off fairly well in the 19th century, taking a societal perspective. In the 21st century, we need to move back to that vision, but with a better understanding and better application. So when you talk about the future of public health, I see exciting times ahead, and I believe we are ready to prepare the professionals for that.
Thank you. Deborah?
Well, what a wonderful setup. There's so much to draw on. I thought actually I would just start off the conversation by reminding us what the process of public health is and adding a few of my observations from more than 15 years of working on maternal mortality in India. We start with evidence, or we're supposed to start with evidence. Sometimes we forget, but mostly. And with evidence, we identify not only key important problems, but problems that we can do something about. We don't always just take the low-hanging fruit, but certainly major problems that have identified feasible answers should be our first priority. And India's done very well at that. Of course, the health problems are changing now, but in the field of maternal and child health, there's been very thoughtful policy making and program development. Next, we have the strategy. And what makes public health different than medicine? Public health is not just big medical programs. Public health is a different point of view and almost a different philosophy, where it's not the individual patient that is our primary concern, it's the society. So in public health, what is our key concern that really nobody else has, and that's coverage. So if you can do a fabulous bypass surgery, but for a very small proportion of the population, that's not public health, as Dr. Matan was pointing out. So we're concerned with coverage and quality, but the quality is not meant to be the best possible care. It's meant to be good care. And I always remember that the counsel of perfection is the enemy of the good. Public health is about good, not perfection. India's done very well in terms of identifying key activities that should be carried forward. The third element is implementation. And I gave a talk in India a couple months ago about maternal mortality, saying called Bridges of Paper, Bridges of Steel. And policies are paper. And what we want are strong programs, programs like steel. And that's where there's a lot of opportunity for improvement in India and a lot of excellent resources. For example, not only do we have public health people, but my favorite colleagues to date, because I'm just getting to know you all, in India is the Indian Institute of Management in Ahmedabad. Professor Dilip Mavalankar is a longtime colleague. How are the health services managed? Are the staff there? Does the water run? Does the electricity work? You know, it's not exciting stuff, but it's critical. And then there's monitoring. This, as the previous speakers have pointed out, is an area that needs huge improvement. But we need to be selective and not just gather more and more information that nobody can absorb or use, but to gather strategic information and to use it. So I would say out of building strategies, implementation, and monitoring, it's the last two where there's so much opportunity, there's so many resources in India. It still staggers me. If you work in Chad, there are a dozen obstetricians, or Mozambique. If you work in India, the Obstetric Society has 30,000 members. So it's really quite wonderful in terms of the resources, but there's a lot to be done in terms of implementation, for example, of the reproductive and child health program that's now underway, several $1 billion, most of it Indian government money. But I worry, really, I do wake up at night thinking about the implementation and the monitoring. So that would be my contribution. Thank you.
Thank you, Jerry. Thank you for the opportunity, and thank you really for a really wonderful panel. I've learned a tremendous lot already, and hope to learn more. I want to take this in some ways to beyond India, and maybe even beyond South Asia, because I think there are lots of lessons to be learned from the Indian experience. Both for that region, but for the world in general. Jerry politely mentioned that I never learn, which is why I keep sort of getting these staying in school, and I do never learn. But one thing that is relevant here, my first degree was in civil engineering from Pakistan. I'm from Pakistan, from the University of Engineering, and my first job offer, which I didn't take, was in the Institute of Public Health Engineering. At the university where I studied, because as a civil engineer in our part of the world, part of that interdisciplinarity that you're talking about is public health engineering, and there's this institute which has since become the Institute of Environmental Health Engineering. So I do know something about building gutters. And if you ever want to build a gutter or a nali, as we call it, ask me. But I say that for a reason, because I think it taught me the importance of those connections that both Dr. Martin and Dr. Reddy mentioned, which are particularly important. And I think that's, I hope, one of the lessons that we all take from here, and I want to take. And I want to pick up on something that Dr. Reddy focused on, which is that along with training, there is this element of agenda setting and policy. And I think one of the great challenges in public health is that. And let me link that to two very eminent Indian colleagues, Indian eminent Indians who have some influence on what we do here at the center. One, of course, is Dr. Amartya Sen, Professor Sen, who was the first Pardee Center professor some years ago and gave a set of lectures here while he was a visiting professor here at the Pardee Center in Boston University, and stressing again this notion, and it's actually quite amazing listening to you how much of what he was focusing on was about public health. And I just want you to hold that thought, and I'll come to it in a moment. And the second is, in a few months, we'll be publishing our first in a new series of publication of think pieces. And the first piece is by the former President of India, Dr. Abdul Kalam. And this is a piece on space exploration. And this is based on his keynote address at our last year, our conference on space exploration. But if you listen to him, you are delighted because he's really talking about development. And he's really talking about the connections that you can draw to issues that we would in this room call public health. and using the advances in other forms of technology. And I say this because I think it is those connections that in your agenda setting are particularly important. As Jerry mentioned, I am housed partly in the Department of International Relations, and I deal a lot with both climate change issues, but also somewhat with security issues. And I want to talk not about climate change as much as security. I think Dr. Reddy is exactly right. We have to look at it as a human rights issue, but I think we also need to convert public health into a human security issue. And that's why I mention Amartya Sen and Abdul Kalam. Because in some ways, I think we need to reach out to public health professionals, but we then need to make connections all across the world between what they are talking about and what these policymakers in other realms are talking about. Let me give just one example and then close. And that example is of climate change, but not in the way that we usually think of climate change in public health. If you look at this, I've served on something called the IPCC for many years, the Intergovernmental Panel on Climate Change, and much of the discussion is, as it should be, on disease vectors, about ecosystems, as you mentioned, and all that. One of the discussions which I think is emerging, which is particularly pressing for countries like India, countries like Pakistan, our region, is the link between climate change and water, and what that is going to do to public health. Water already, the picture we have on the poster for this event is there for a reason. Water and public health are particularly entwined, and water and climate are going to be particularly entwined. When we think of climate change, mostly in industrialized countries like the US, we usually think of energy, because energy is the cause. When we think of causes, we think of energy. When we think of climate change and policy, we think of energy, oil prices, and so on and so forth. When we think of climate change impacts, the science is becoming more and more clear that they are first going to be primarily about water. They're going to be about water disappearing. They're going to be about water melting, particularly in our region. They're going to be about water restricting. And they're going to be about water just falling off the sky in natural disasters. And all of those are going to affect and create a greater need for a public health awareness of those linkages. Let me give an example, and I've thought a bit about whether I should or not. Because the exit is far away, and between this Pakistani and the exit, there are lots of Indians. So I hope you'll hold the spirit of that laughter as you hear this. I've said this to my Pakistani colleagues, and with similar concern. I did a book on human security in South Asia with colleagues from all over the region. One of the most interesting back-of-the-envelope thing we came up with, it's really back of the envelope, but I think it's telling. 60 years of wonderful relations between India and Pakistan. 60 years of constant violence. I know this is a tricky subject, but I'm not making a political point here. I'm making, I hope, a public health point. 60 plus years of constant tension and violence and multiple wars. Total number of Pakistanis killed at the hand of the Indian side is less than the number of children in Karachi who will die in any 1 year because of dirty water. Exactly the same number is true on the Indian side for New Delhi. This is not a political point. The point is that if you are the mother of that child, it does not matter to you whether your child died at the wrong end of a gun or the wrong end of a tap. The child is equally dead. Yet we somehow talk about one as being more dead than the other. Right? This is true globally. The point I'm trying to make is we don't know what to do about the gun. We do know what to do about the tap. Right? That's the policy message. So somehow I think we need to turn public health into a human security issue, because I think the payoffs are much, much greater. And that is why we need to bring it back to the Amartya Sens of the world, to the Abdul Kalams of the world, and to the public health engineers of the world, and make those connections between these disciplines. So all of this to say, extremely excited to learn about your plans, and good luck and Godspeed.
So that's a wonderful introduction to a conversation that we hope you will vigorously engage in. First, I want to say that I'm really delighted to see not only our group from the T5 program, but also so many people from various parts of the university who are interested in this topic, in this field, and willing to walk over to the Pardee Center at this end of the campus on a still warm day in June. Our four speakers have put down a number of challenges, not all that I could possibly think of, but some rather important ones. So let me try to very succinctly pick out one or two things that each has said. Dr. Mauthan really, in addressing how to get at the challenge of the 750 million below the poverty line, or the 350 million who are at abject poverty levels in India, saw a very strategic challenge. And that strategic challenge was within the government health system, which is a lifeline for most of those people. And the government health system does not function at the level that it needs to. And how do you make it do that? I think he was talking about subversion. You infiltrate the government cadre with people who understand the population-based issues, and armed with that understanding, evidence, as was raised during the course of these remarks, try to identify the solutions working from within that system. You cannot create good health in India without the government and the government health system being a part of the solution. So he starts with a very strategic issue, and he's looking to build competency. Srinath took it to another level, because he's looking at everything that surrounds that government health system, and going from the issue of the competency of the people to figuring out how you deliver better health. And he touched on a number of important issues of why health is important. The Jeffrey Sachs model of development says that you can't grow an economy without healthy people. And when Jeff Sachs and colleagues did an analysis of the Asian tiger economies, the most important thing, and they could actually put a percentage of GDP growth on improvement in child mortality, reduction in child mortality, equal to 1% of GDP. Suddenly, public health measures become real to economists when you can say 1% of GDP is related to this one strategic decision. And that child survival, improved health during childhood, better learning capacity, turning out smarter people in their working years, was probably the most important single factor in the development of the Asian tiger economies. So this huge number of people under 25 is an incredible target of opportunity if you can figure out how to deliver. And he touched on the interdisciplinarity issues that were so important. And if I would characterize what Dr. Mauthan was saying as competency, I think Srinath was also talking about advocacy. But both were talking about both. Deborah presented a very important model, which is that you actually have to start with evidence. You have to know something about what you're talking about. If you're really going to be strategic and most efficient in the use of limited resources. And going from that, starting with evidence, to prioritizing, developing the strategy, figuring out the implementation, and then monitoring what you do so it feeds back in the loop. That's a pretty good definition of public health. And then Adil said it in a slightly different way, because he used the word connections in multiple ways, almost defining public health, not as most of us would do at the beginning, which is to say it's about population-based health. He said public health is about connections. And the connections don't stop within a country, they cross the borders. And while he was not simply talking about India, Pakistan, there are lots of common problems that are being addressed independently that could do much better collecting evidence if the connectivity between the two was real, that the lessons learned could be shared, and somehow I have the belief that if you actually do that, the tap becomes much more important than the gun barrel, and that's a strategic, diplomatic way of addressing security issues. So in converting public health to a human security issue is what he said. I think he rightfully points to water as one of those most important commodities that will be the source of conflict, the source of war. It's not just going to be between India and Pakistan. In this country, it'll be between the state of Georgia, Alabama, and Florida, and California, Washington, and Oregon. It's the same sort of issue, and these connectivity things become absolutely relevant, and we need to be well aware of that. So that's sort of a very brief attempt to summarize a huge area of information that our colleagues have provided. Now we have lots of time to question, to challenge, to bring up things that we're missing, and I invite everybody in the audience to comment. If you would, when you're making a comment, please stand up. Tell us who you are and where you're from, whether you're from inside the institution or from outside, and speak loud, because if you're facing this way, people behind you may not be able to hear. So who's the first bold soul willing to open up? We have a bold soul right here.
Well, I will start for some more expert questions. So my name is Mei Ye. I'm an assistant professor in international relations, so I don't do public health. Okay, I guess this one isn't open, right? Is it working? Oh, just for recording. You don't need recording water. So I compare China and India in their economic reforms. I'm very interested in the mutual lesson that the two can learn. And I'm not clear about the Chinese lessons, but I'm wondering that given India's long experience in coping with the public health challenge, what kind of today we can talk about the weaknesses, but I would like to ask you what kind of lesson that the other developing countries that are also facing the same challenges as India that can learn from India. And the second question is about the globalization of public health. Well, from both speakers' points that I see that the international exchange and the Western patients like outsourcing of public health in India. So those trends, when did they start, and how those internationalization of practice influence public policy making in India in this sector? Okay, thanks.
So there were two basic issues that were raised. One had to do with lessons that might be common or different between China facing similar kinds of problems as India, maybe different system in the country. How do they learn from one another? What's common? What's different? How do they interact with one another? And the second had to do with the influence of globalization and how that's going to impact on our attempts to solve some of the challenges that were discussed. Who'd like to? Srinath?
Okay, well, I'll start and then Srinath can do it, and the next question we'll do the other way around. I had the opportunity to go to China as a tourist a year ago, and what struck me is the number of beggars on and around Tiananmen Square. And after I got to know him better, I asked my guide, why are these beggars here? I thought you have a communist thing where the state looks after everybody. So he looked at me strangely and he said, "Sir, suppose I fall sick with a serious illness and I need hospitalization and treatment and my family pays for it and I die after 2 years, my wife and child will be sitting there begging." Now, India has a social support system in which both the government and the private sector, by which I mean the family and friends, play a great role. Healthcare is available to everybody in the government healthcare system. Only thing is it's inadequate to cope with what is the volume of work that needs to be done. And I'm proud of the fact that if you require a coronary bypass and you happen to live in my state, that is Tamil Nadu, you can ultimately get a free coronary bypass in the Madras General Hospital if you belong to the below the poverty line group. But you have to wait so long that you may not survive till your number comes up. But there are people regularly who do get through the process and get this done. It's not possible in many developing countries. So in spite of privatization, globalization, market economy, in any country which has a significant poor segment, there has to be government support of health and of public health. That, I think, is the first lesson we need to remember. And if the statistics I have seen from India are correct, I understand 35% of the population of this very affluent country has no access to health care. I think you have something which you need to learn. The government has a role, and after all, health is a fundamental right, and the government needs to maintain the access of the people to fundamental right. So that's the positive lesson from India. Influence of medical tourism, I'm the wrong person to talk. I'm ashamed of it. It's crass commercialization. The government subsidizes it by giving them huge tax benefits. I believe the government needs to tax them double and use that money for the treating of the poor people and for the public health system. I'm accused of being a socialist, but I've been one all my life, and I'm not ashamed about it.
Well, I think India and China have a lot to learn from each other of things that they should do and things that they should not do. Initially, after independence, which came almost close together, China set off on a much different pattern. While India declared itself to a public sector model of healthcare, its outreach was still rather limited. China emphasized agricultural collectives, built the healthcare system around the agricultural collectives, established a three-tier system, which functioned fairly well and ultimately resulted in much better improvements in the health indicators. But then China, around the late 80s and particularly accelerated in the 90s, swung around to a very accelerated policy of economic liberalization, which dismantled much of the health structure. You found that the out-of-pocket payments jumped up from somewhere around 30%, 32% in late 80s to about 60% by year 2000. Even now it's about 56%. Then you found that the government funding of some of the rural health centers and even the secondary health centers came down to 25% of what they were funded by the government earlier. So essentially, all of these centers, while functioning under the government, had to develop a private sector mindset in which they were charging for drugs, they were charging for other services, and ultimately you deprived a large number of people of affordable health care, even as rural economies suffered. And that is why the health indicators in China have actually not done well in the last 10, 15 years. And therefore, there has been a serious reconsideration, as you know, at the level of the state council. And now the insurance, which was available only for employer-protected insurance in urban areas, now they're thinking of a rural health insurance scheme. So what we in India must learn from China is that even as you embark on a policy of economic liberalization and freeing up the market, as we are doing, ensure that there is adequate protection for public health and health. Even in conditions of macroeconomic instability, health sector must be protected. And particularly, you cannot privatize health at abandon, and that too with an unregulated private sector as it exists in India. It can be counterproductive. So that's the lesson we have to learn from India, not to go down the Chinese path. Of course, there are lessons that can be learned from India in the sense that, as Professor Martin has already pointed out, there has been an emphasis on public health services delivery and substantially state subsidized delivery of services. Again, we also suffered this distortion, and our out-of-pocket payments are even worse than China. They're currently about 80 to 82%. So now there is an attempt to try and see whether the National Rural Health Mission and the Urban Health Mission, all of them can actually provide better access. But I think our success story, to some extent, has been in building up a fairly credible primary healthcare infrastructure, though its functioning has not been adequate. If we invigorate that existing primary healthcare infrastructure, we can actually make rapid advances. In terms of internationalization of public health, I agree that many of the determinants as well as the decision-making processes are actually shifting to a global level. And the common challenges, the interconnectivity is very apparent, not only because of bioterrorism and the threat of SARS and avian influenza, but you're finding out what is happening in food security, you're finding out in global climate change, you're finding out in drugs. Everywhere there is a awareness that there needs to be concerted global action. But then the global governance of public health is very poorly defined. Now, how do you have a shared sovereignty in which you can actually, countries can sit together and decide what is good for the world? That whole global governance structure has to emerge, and maybe experts in international relations like you can actually help develop those robust systems. I mean, we do need to take care of public health at the national level. It has to be fundamentally a national commitment. But there also has to be a reasonable level of global governance for ensuring that health, which actually is impacted upon by a number of global factors, is adequately governed.
Deborah, any comment?
Yeah, I was just thinking about some of the things that are going on. I find working in India exhilarating and frightening because so many countries you think, gee, if they'd only do this and that, and in India things happen so fast that you sort of feel like, whoa, let's test this before we go national. But there are a number, in terms of maternal and child health, there are a number of big programs now where there's an underlying assumption that demand will create supply. And I think that's a critical idea because it has to do with this whole public-private sector debate. And so, for example, now the government in India is paying women to give birth in facilities. They haven't improved the facilities, which was meant to have been done under several other programs. But now they're paying women. And so facilities that were working fairly well are now swamped, and facilities that weren't working well are just more crowded. So I think that in terms of lessons, I'm not sure where the lesson comes from and who should be applying it, but I think we need to be thinking about what is this relationship between supply and demand. And the assumption that demand by poor people will create supply is just not true. If poor people die, it doesn't create demand that affects the system necessarily, unless there are champions such as our colleagues here. But we can't just assume that that will work out. And I think that's a critical international issue right now.
Because there's too much of a supply of poor people.
Well, they don't have political clout. They've been dying for millennia, and they're still dying. And that doesn't create a big problem for anybody unless we make it a problem.
Adil?
Not right now.
Anna, and then Umakant.
Hi, Anna Karina Mascarenas,
Anna?
and sorry, I need the taping thing.
Right, so speak up
Speak
to
up.
the group.
I'm Anna Karina Mascarenas, and I am faculty at the BU Goldman School of Dental Medicine. I'm the graduate program director for dental public health. So I have two comments. Not going to wear my dental hat just now for this one, but I did grow up in India, studied in India, and came here to grad school. And one of the things I always remember when I go back is when I was in school, we had this subject called community living, which I hear now is no longer a subject in school. And I was wondering if you could comment, because that really taught me basics on health, on living. When I go back, I think one of the public health problems in Goa, where I come from, is the road system and how people drive. So we had something like that back, and with you starting a new institution, kind of working together with the education institution in India at the grassroots level and to primary education, and getting some of that back into the curriculum will also help the outcomes for public health in the future. So that was my first one. The second is I would definitely like to make a plug while we start this at the grassroots level and you're just starting your programs to include oral health in your programs, because of all the new evidence we're getting that oral health is part of the body, and then there was diabetes outcomes, was cardiovascular outcomes, and several outcomes because of poor oral health. And again, primary prevention.
Thank you.
Well, Goa must have been one of the unusual places where there was a subject called community living. Of course, Goa is the poster child for good living, Dolce Vita, but community living, that must have been nice too. But certainly, some elements of hygiene were incorporated into several school programs, and now there is an attempt to reintroduce some of these issues along with environment. But certainly a lot more can be done in the school setting. Second, as far as dental public health is concerned, we are on the job.
My name is Umakant. I'm a doctoral student at the School of Public Health at BU. And back home in India, I'm a civil servant on a study leave to the US. My question is to Dr. Reddy, and I am picking up where Professor Deborah Main left. Dr. Reddy, in your opening remarks, you referred to some of the points on the policy agenda for public health in India, and you made a mention of how the policy agenda has to interface with the free market and how to engage the market in a response to public health challenges in India. So could you give us an example or two of how and what shape that will take, what exactly product or services will come from the private sector to address some of the needs of the public health in India? And also, as Professor Deborah Main was saying, with a lot of these women, for example, under the Janani Suraksha Yojana, landing at these public facilities for delivery services, and the facilities not equipped to deal with such influx, is there a role for the private sector to step in and provide these services, which actually primary health services, and also some services that do not really present a big business model for the private sector?
Well, as far as the question of dealing with the market is concerned, we must recognize that the government sector has a very important role to play, but is currently inadequate in terms of its outreach of services. Therefore, the existing private sector in all its forms must also be recognized as a potentially valuable player and must be appropriately harnessed. And of course, the small but fairly well-committed voluntary sector also must be encouraged to grow. So my prescription, therefore, for this has been the public sector must be more responsive in terms of increasing the outreach. The private sector must be more responsible in terms of its ethical conduct. And the voluntary sector must become more resourceful. But having said that, we do require certainly appropriate regulatory framework. Because right now, we have a totally laissez-faire system in which the private sector is totally unregulated in terms of its pricing, in terms of quality. And to some extent, the government sector is also not being regulated for its quality. So getting an appropriate regulatory framework is absolutely mandatory so that we can actually integrate all of these in a more systematic fashion and delineate what kind of services can be provided. The services can be a variety of public-private partnerships, of course. But then again, those public-private partnerships cannot be left undefined and unaccountable. Contracted services are being done even now, but again, the terms of the contract and the quality of care has to be sort of monitored. Then the whole area of insurance, whether you're going to have a single provider insurance system with private insurance participation along with social insurance, is there going to be a common regulatory framework so that there's no adverse pricing out? I mean, adverse selection and other issues of private insurance, which are the major issues, do not corrode the insurance system that is emerging in India. All of these are issues that need to be carefully looked at. I believe it's very important for the government to remain the main custodian of this whole exercise. Universal health assurance as I call it, is absolutely important, that the government must provide the assurance of universal health access. It need not be the main provider, but it should be able to build the framework and regulate the framework in which all of these can be interfaced. Then coming to the Janni Suraksha Yojana, which is your specific example that you have raised, I believe that this example in Gujarat, where the Chiranjeevi Yojana has actually contracted out services to private obstetricians for institutional deliveries, has been quite effective, and you are, I know, engaged in an evaluation exercise. But the same happy situation doesn't exist in a number of other states. In North India, for example, even the private obstetricians are not available. So you have to look at alternate solutions. Either you have to train more people and deploy more people and then take reluctant doctors kicking and screaming to the villages, which may be very difficult, or think of task shifting. Why can't we think of nurse anesthetists, nurse obstetricians? We have to think of alternate cadres. So we have to then also ensure that our regulatory framework doesn't become a straitjacket in which nurses are being allowed with appropriate training to perform some of these functions. So we ought to be really able to look at our health force requirements and deployment in a much larger frame, and we need task shifting where nurses can perform functions currently assigned to doctors, multipurpose health workers can perform functions currently assigned to nurses, and also we need task sharing. Multiple vertical programs need convergence so that redundancy is avoided and multi-skilling is possible and people can do jobs across different programs. And I think that way we can increase our access.
Deborah, any comments? No. Yes. And then, first here. Go ahead.
My name is Manikam. I come from India. I belong to. My name is Manikam. I come from National Institute of Epidemiology, and my background is that I'm a trained physician in Indian systems of medicine. I have a quick comment and a quick question to the panel. I'm happy that in any public health fora, India and China has to be talked. There's no way these two countries can be left out in a discussion on public health. I'm happy that I'm sitting next to a person who is expert in China. When the question came, what can we learn from China? I have been debating this and I have been discussing with my colleagues that one thing which I can, with my background, I thought I can learn, or India can learn, is the way they have utilized the traditional Chinese system within the healthcare domain. And that is my comment. My question is, what do the panel think about a large workforce trained by institutions recognized by the government working within the system? What can be their contribution to the public health that we are talking about?
You have asked a very interesting question which has exercised health policy makers for many years. The legal position as spelled out by the Supreme Court of India is that unless you are trained, certified and licensed in the Western system of medicine, you cannot practice Western medicine. There are ways in which you can work past this, but the judgment is very, very clear. And we had a big problem because ICMR has this project where we are using untrained village women to give injections of gentamicin to young babies with respiratory infection to see whether it can be operationalized on a national this thing. And we finally had to get an advice from the Chief Justice of the Supreme Court of India that given the research framework, this was permissible. So the answer, Manikam, is that at the moment, I don't think there are any regulatory policies which will allow this. The big difference between traditional systems of medicine and treatment in the modern system of medicine is the enormous amount of empiricism in the traditional systems of medicine, which you yourself know. And their treatment is individualized and personalized. It's not, if you have pneumonia, give this antibiotic. And this is going to make it very, very difficult to make that part of the other more. But our state government, for example, has now got indigenous practitioners working in government hospitals practicing indigenous medicine. Srinath, do you want to add something to that?
Well, there are major regulatory obstacles to people practicing the full range of medical care. But certainly, people who are already trained in alternate or complementary systems of medicine or traditional systems of medicine, if they can be supported to practice their craft as they're already being deployed in primary healthcare centers and other areas, with appropriate support, at least they'll be able to provide some level of care, especially in chronic care situations where the systems have been found to be more effective and well received, though they don't necessarily work very well in acute care, in acute care situations. But one area where actually they can be very helpful is the whole area of health promotion and prevention. After all, most of the traditional systems of medicine emphasize healthy living. So we ought to be able to capture that element of it and at least make them very strong public health professionals in that area.
Yeah, I'm no expert on the substance of the question, but Manikam's excellent comment sort of spurred another question in my head, which I just wanted to throw out, because it seems we haven't talked about that and it might be central. Maybe it's central to me just because we are doing something on that at the center here. And that's about global mobility. Your professionals in all areas, but particularly in health, are extremely mobile people. They're extremely in demand. So as you think about training, do you see any sort of global impulses that might actually sort of extract out these people? I've heard this figure, I don't know how true it is, but I think from the American Association for Indian Physicians and the Pakistani physicians throw out the same. I don't know how true it is, but it must be close. What I've heard is that the average American in America who can go to any doctor is more likely to see a South Asian physician than the average South Asian in South Asia is likely to see a South Asian physician. Now that's largely a factor of the denominator, right? You're dividing by a larger number, but even if closely true, it's an interesting question. And so as you think about training and leadership, and particularly health professionals being extremely mobile, what impacts does that have? Is something that might be interesting to think about.
Deborah?
Yeah, I thought about the traditional medicine. If you look at the reality of healthcare, public healthcare in India now, my suggestion would be keep it simple. Set priorities. Traditional medicine is going on. It would be nice to bring it in the way they have in Bhutan, and they have lovely traditional pharmacies in every facility, and it's all very nice and neat, but that's a tiny country. I would say, the fact that less than 50% of children in India get basic immunization, which we know works, that family planning still means sterilization in most public health facilities in India, or else there's no family planning. That emergency obstetric care is not available, and so women die in district hospitals all over the country, in FRUs that are meant to be doing cesarean sections, but they're not available. Let's keep it simple. What's the basics that are meant to be there right now? We need implementation, we need monitoring, and let's not fancy it up anymore before we do the basics. That would be my plea.
Now, just a comment about the mobility of the South Asian physician. Yes, you do see a lot of them in this country, but there are lots more who stay back. And it's not so easy for a physician to be mobile to this country because, thankfully, of the regulatory framework in this country. And I'll just tell you something funny that happened to me over 20 plus years ago. The Royal Royal College of Physicians of London gave me an honorary FRCP around 20 years ago. And with my tongue in cheek, I wrote to the British General Medical Council with a photocopy of this diploma which they had sent me and said, would you now register me in the General Medical Council register? And I'm happy to say I never got a reply from them.
Well, there is always the threat of global migration, and particularly for physicians, of course, where people are in short supply, they will somehow migrate, if not to the US, to Gulf or anywhere else. For public health professionals too, there is possibility of their getting absorbed into some international positions and so on. But I believe that if we produce people in large enough numbers, and more importantly, during their training, provide them sufficient connectivity to the ground realities and root them in the system, the level of commitment to stay back and serve would be much higher. It depends partly on the kind of institutional training and the values that are embedded in the training, and not entirely dictated by market forces.
Yeah, I'm Narasimhamurthy from the National Institute of Epidemiology. In fact, the lectures given by Professor Reddy, in fact, it is very elaborative. In fact, provoked the thinking of the community, in fact. And I have enamored by the way the lecture was given. In fact, I was really thrilled. But the one question which really boggled me is that several times, because I am not a physician, or I am a statistician, biostatistician, and a demographer. Various platforms, the people think that the various National Rural Health Mission, National Urban Mission for the public health, various programs are launched by the Government of India in order to increase the health of the community. But various issues are discussed at the platform in the Parliament section. The only question that they decided was, including the MDGs, the Millennium Development Goals were established, they said the ultimate aim for the country is to population control. How do you think that the population control, in terms of your health, developing health programs in the National Rural Health Mission and the Rural Urban Mission, in terms of, for example, if I tell you the Panchayat Raj system, which was established earlier, didn't do well. And the Panchayat Raj system, nobody speaks now. What happened to those systems? What I mean to say, that I am not critical about the public health per se in future for the country as a whole. I feel that what is the ultimate goal for the country in order to establish public health in the community?
Well, I'll take the question particularly related to the population control issue straight, and then maybe other issues we can discuss subsequently. India's experience in population control was dictated in the 50s and 60s by the Malthusian perspective that a large population is always going to be very dangerous because it is going to be a major drain on resources, and therefore all methods must be employed for population control. And this reached its peak during the infamous emergency when almost coercive sterilization procedures were followed. Part of this was Western thinking that was actually exported to India. But certainly there were legitimate concerns as well. Now, the government of India doesn't talk of population control at all. They talk of population stabilization. In between, the thinking also emerged that from family planning, we went to family welfare. Because we recognize that in states like Kerala, with increased education of women, increased participation of women in the workforce, the population growth rates came down without having to really go around doing a lot of family planning related health education or doing compulsory sterilization type of processes. It was entirely a response to very equitable development. And now, therefore, the emphasis shifted that you have to reduce infant mortality rate to give women incentive to have smaller families, and so on and so forth. So family welfare came as a concept. Now with the concept of a demographic window of opportunity of young and fairly able people contributing to a large workforce, people are talking about population stabilization, not population control as such. But we still have to avoid a very large population, because apart from being a drain on various resources, it's also an environmental threat. So we have to recognize that. But the solution is not unidimensional, it is multidimensional. You have to educate people, you have to reduce infant mortality rates, you have to do a lot of other things in order to reduce the fertility rate. And we have to focus on all of those efforts through a public health program.
Hi, there's one other thing, and I think that this is an area where, and India is so impressive, especially when you're there, that it sometimes seems like there's nothing to learn. But here's an area where many lessons have been learned all around the world in poor populations in Bangladesh. And the missing concept I often feel in this discussion in India is services. You know, it's either you neglect women or you force them. Or it wasn't just women in the emergency, it was men too. And the concept of, and actually under RCH2, I was working with people who were designing it to get the idea that I was in a big meeting in the planning of RCH2, and I said, yes, we could have family planning at the PHC, and everybody said, no, there's no surgery. And I said, who said anything about surgery? Remember family planning, the woman comes in and the nice lady talks to her and presents a lot of different methods, and then she chooses. That has still never happened in India. And the concept of, you know, there's been very good work done showing that if women who want no more children were able to use modern methods of contraception, fertility would go way down in India. There's no need to be setting targets. There's no need to be pushing sterilization, often because those women are pretty old and have a lot of children anyhow. But the whole idea of voluntary cafeteria-style family planning has still never been implemented in India, and I hope I live to see it.
Now, people can be very pragmatic. And so if we think about the influence of globalization, the need for education, and the cost of education, people are going to figure out that they can't afford to educate innumerable number of children. They're going to have to, of necessity, to deal with the contemporary 21st century world, reduce family size. And they'll do it. They need the information to act on.
And they need the services.
And they need the services, right. So, right here, just take the microphone and identify yourself.
Yes, I'm Bill Anthony. I'm a professor here at Boston University. I direct a Center for Psychiatric Rehabilitation, which is a research, training, and service center dealing with people with severe mental illnesses, bipolar disorder, depression, schizophrenia, etc. A comment and then a question. In the United States, I think the mental health system is starting to gradually move towards a public health perspective, where we're not just concerned with symptom reduction, we're concerned with employment, the criminal justice system, certainly the healthcare system, where people with severe mental illnesses die 10 to 20 years before on the average non-mentally impaired people. So we're moving towards this public health system. So one question I had was, what's happening in India in the public mental health system? The second question I had was, one of the things that is happening here is we're starting to develop what we call peer providers. Those are people with severe mental illnesses who have recovered from mental illness and who are now providing services to essentially their peers. And of course, there's been a lot of resistance from the professional community about this, but it is now a service that in some states is Medicaid reimbursable. State departments of mental health are reimbursing it. It's really moving along. So I also wondered, besides the question on public mental health perspective in India, can you ever envision peer providers who are people with mental illnesses, recovered from mental illnesses, providing services in India? Thank you.
Well,
Go ahead.
mental health is an important problem in India, but even practitioners of psychiatry are grossly inadequate in number, and it's something which will have to be incorporated as the public health system grows stronger. There are government-run mental hospitals, but they are essentially for custodial care. And the treatment available for people who have a variety of mental health problems is inadequate.
We have a serious shortage of psychiatrists in India now, which is getting aggravated by a large number of our psychiatrists being sort of attracted to the United Kingdom. What it says for the state of mental health in India and UK, I do not know. But certainly there is a large flight of psychiatrists to the United Kingdom.
It says something about the state of mental health in the United Kingdom.
Yeah, that's right. So now, but we do have a major national health program that has been envisioned by the government of India, and like all national programs, has a district model. It's reasonably well conceived as a community-based mental health program with a wide outreach of services. But again, it's languishing because of inadequate human resources. There are no trained people, even non-psychiatrist mental health care providers or managers of the mental health program, they're not available. So we have a huge training need to make this national mental health program, which is fairly ambitious, reasonably well-resourced, effective. And the critical crunch is lack of human resources. And one of the things that we will be doing is also to try and provide non-physician care providers, not necessarily peer care providers, because that's not a model that's been really looked at in India. I think at the moment, the only place where peer care providers providing mental health support exists in the political parties.
And not functioning very well.
Can I again, as the non-public health guy here, that's a very interesting observation you made, and I just wanted to throw an example which is not from India but from Pakistan. But from what I hear, it was also true in East Asia with the tsunami. And so, I mean, in some ways, the traditional system of mental health is only the peer system. It's your grandmother, your chachi, your mommy, who, so someone in the family who'll give the counseling, if you will, in some form. But the reason your question struck me is that for those of us who do development, immediately after the earthquake a couple of years back, a major crisis sort of emerged in the relief agencies, who could actually find physicians for what were obvious medical emergencies, but what the earthquake did was it sort of broke up families. Kids, no parents. Mother, 4 kids dead. And you have this immediate need for the type of counseling that I mean, again, sort of it's a broad spectrum, but again, with the tsunami, one hears that need again came up. And therefore, I think a lot of these countries, developing countries, should be thinking much more seriously about this within that public health sphere, in my sort of non-expert view.
I think we need to think about who the provider is, and it's not necessarily physician-trained psychiatrists. And even for the delivery of medication, mental health, some of it is addressable with drugs, but not all of it. And you don't have to be a physician to actually dispense some of the meds. They're quite safe, and people can learn how to dispense and monitor them. But it comes down to moving it down and developing the system to provide that care with the relevant kind of supervision. And I think the medical profession doesn't like to think of anybody else delivering care and their role being more of a supervisory level. And as long as we're thinking medicine, one physician, one patient at a time, we're not going to solve that problem. So we really need to be inculcating the public health service mentality into medical training.
Paul Bolton and colleagues, who until recently was at BU, did the impossible. They did a proper study of peer counseling for traumatized people in northern Uganda, and showed that it was very effective. I can find that reference for you, but Paul Bolton, if you look that up at Uganda, it should come up. The thing I would make a plea for is that in our efforts to expand services, there can be a phenomenon which I think of as a plague of nice ideas. And for example, in maternal health, we've spent decades, wasted decades, pursuing nice ideas that really couldn't work. So with all of these ideas, with all of these new ideas, they need to be carefully evaluated before they're scaled up. And this is something that worries me a lot in India. The Asha idea was never tested. This is a woman who's meant to help the woman get to proper delivery care. It's a nice idea. Does it work? nobody knows and nobody will know because it's been scaled up now. So we just need to be very careful with these ideas, and I think Paul Bolton's work in Uganda shows that anything can be properly evaluated.
We'll take one last comment here, sorry.
I'm Biju Soman. I'm coming from Sri Chitra Tirunal Institute of Medical Sciences, which is the first institute to provide an MPH course in India. I'm glad to be here, and I feel privileged to listen to our panel discussions. And I was teaching public health for a couple of years, and I was holding the same beliefs as Professor Martin. Like I used to say that in public health, the marginalized sections of the community, they are the natural allies of public health professionals. So we should consider them in the forefront. But it's a major challenge that Professor Reddy is raising, that we have to move from molecule to market. And so I'm coming from Kerala, and you know that Kerala has done quite well in the health sector compared to rest of India. And we have achieved that through the principles of socialism. We have provided universal education and tried to provide universal coverage of healthcare, and that's how we are done. But I know that it's not easy to replicate Kerala model to rest of the country. And but the to me it's a wonderful it's a breakthrough that we have to consider how best we can harness market to invest in public health. So, but I think that path to take market into public health should be done in a very careful way. Otherwise, most often market can hijack this one. And I'm still wondering what can be the interest of market forces to invest in public health, to invest in the welfare of the most downtrodden in the community. I know that there are ways, and I take this as a challenge. Probably this is going to be one of the remarkable days of my professional beliefs. But I'd like to, like Dr. Reddy, to bit more expand.
No, I'd definitely like to reply to that, because there is a misunderstanding which may have been created by my communication. I did not plead for the market to dominate public health or healthcare. Let me make that very clear. I believe the market has a role, but must be very strongly regulated. I believe that the government and the public sector must control the main levers of public health policy and planning, and especially in a country like India. When I said molecules to market, I said our research must look at how the dynamics of the market are influencing health, and in turn we must help to regulate that market in the interest of public health. Whether it is tobacco control, where the market has to be regulated, whether it is removal of trans fats from the food, and so on and so forth. There are multiple areas where the market interacts. And therefore, if the market is actually adversely impacting on public health, then we ought to establish the primacy of public health over the market. That is what I said. I didn't say that marketize private health, public health, not at all. Please, let us remove that misunderstanding once and for all. Now, but the issue here is that the market, unfortunately, is here to stay with us. And therefore, it is important for us to study its dynamics carefully and try and regulate it as effectively as possible. And that we need to do in multiple sectors. I mean, even when you're looking at the food crisis, for example, what is its downstream impact going to be on nutritional status, on food security? These are all public health challenges. You cannot say that I have nothing to do with agriculture, I have nothing to do with food processing, I have nothing to do with urban development and urban transport. You cannot leave it entirely to the market without challenge. A public health professional must understand these dynamics and must effectively advocate for interventions. At the same time, there is a limited area in which you can actually engage the private sector as a potential partner, not only in healthcare delivery with appropriate regulation, but also point out the health dividend for the larger private sector. After all, if people live healthy and live long, the labor market will be more secure, the consumer market will be more secure. And therefore, other than industries like tobacco and some elements of the food industry, the larger private sector, in its own enlightened self-interest, must contribute to strengthening public health. The elements who are closely engaged in healthcare delivery, the private sector healthcare industry, must also be given an appropriate role, but with suitable regulation. But there, the government must not lose its levers of control. That's what I said.
We're actually, according to my watch, we have a couple of minutes left, so I'm going to take one more from the young lady right here.
Hi, my name is Amita. I'm a master's student of international relations, and this question is for the panel. So clearly, population is a huge issue in India, and I think that the ability of the government to disperse public health initiatives is limited because of the size of the population. So I'm wondering, any thoughts on collaboration between the government and NGOs?
Government NGO interactions because of the size of the problem of the population needing better health care?
Well, in terms of contraception, I think, if you look back at the emergency period in India, the worst thing that could have happened to contraceptive choice, to contraceptive decision-making or family planning in India was the push on sterilization and the focus on sterilization. And there are zillions of wonderful NGOs in India, but very few of them, I think, have anything to do with contraception. And I think a lot of people just backed away, and fertility has come down, but I still yearn for the old-style, multi-method, voluntary contraception, which I think would take India a very long way.
I agree. I mean, we do definitely need to address the issue of providing more information and services to the people. And the NGOs have a role of extending the outreach of the traditional government services, especially in the area of education, and to some extent in the area of services. And the NGOs should be utilized as valuable partners. And the civil society partnerships are indeed now recognized as of being greater value, even in the National Rural Health Mission and the National Urban Health Mission. They are being provided a space. But let me just give you an example totally outside of India. I know the reference to Iran is not always welcome in the United States. But when I was there in a WHO meeting for chronic diseases, training for the entire West Asia, I had an opportunity to visit a district hospital. And apart from the cardiac rehabilitation services and so on, which were shown to me, as I was passing along with my colleagues from other countries, we found a lecture theater there. And out of curiosity, we asked what was going on, and then we were led there. There were about 50 or 60 couples to be married. Women on one side, men on one side. But we were told that's a compulsory course for all couples wanting to get wed in reproductive health, contraception, child nutrition, child rearing, without which the marriage would not be considered acceptable as a legal marriage. And this is a compulsory course in Iran. I wish India could do that. Certainly. I mean, you do require to carry education to people and let them make their choices, provide the facilities. And this is where NGOs can step in. The government may not be able to do all of this. NGOs can step in.
Yes, the government is not able to do it because of political pulls and pressures, but NGOs can certainly do it.
Okay, I'm going to do a 5-second summary, and then we can...
5 seconds over.
A handful of words that I think represent the challenges and the things that we've heard about. So one is the issue around competency, of improving competency. The second is getting the message out and the advocacy, and that ties very much into education, which we talked about only peripherally, and education at all levels, education in public health, education of the politicians, decision makers, education of the public, and as an intermediary, education of the media to convey the right kind of messages. The issue around the connectivity, the multiple sectors that are involved. From a global perspective, there's got to be a global collaboration because the issues are not confined to any one country or, in fact, any one region. They are truly global. And finally, where Deborah was talking about focusing on the good and the possible. But with a public health perspective, you have to say there's always a striving to be better. So I want to thank our two participants from India. Both of them have flown in just in the last day or two, so they're a little bit jet lagged, and they were right on and sharp and really perfect. That was great. Deborah, for your comments, and Adil as well, and thank you for making the space at the Pardee Center available. We love the collaboration across the campus. To the audience, the members of the T5 program, and everybody else who came and participated, thank you very much.